Hi, my name is Chen. I am the director of the transplant and cell therapy programs here at Mass General Hospital in Boston. Acute myeloid leukemia, or AML, is the most common acute leukemia that we see today in adults. The presentation and the diagnosis are quite varied. And it's because it can present in several different ways. So acute myeloid leukemia is a proliferation of cells called myeloblasts, which are your very early blood stem cells, and they generally will proliferate in your bone marrow. And as a result, they will block out the normal function of your bone marrow, which is as a factory to produce your normal blood cells. How one presents is somewhat dictated on which cell line or blood cell is affected the most. So your blood cells generally have three different types that we think about. They are your white blood cells, which function in the immune system to help you fight infection. There are your red blood cells, which carry oxygen to your muscles and other parts of your body for energy. And there are your platelets, which are these very small cellular fragments that if you cut yourself, they rush to that site and help you stop bleeding. So as your bone marrow starts to not make enough cells, one can imagine you can present in several different ways. If the leukemia cells spill out into your blood, you can have a very high white blood cell count full of leukemia cells. That's a very dangerous situation and almost a medical emergency, depending on how high that count is. It can lead to a phenomenon called leukostasis, where these very sticky leukemia cells can get stuck in the small capillaries of certain organs. And the most common presentation includes confusion or other problems thinking, and also shortness of breath or trouble breathing. If the white blood cell count is too low and the leukemia cells are staying in the bone marrow but blocking production of normal white blood cells, patients are predisposed to infection. And the most common way they present is with a fever because they just don't have the normal white blood cells to deal with even the healthy bacteria or other microorganisms that live inside all of our bodies. If the red blood cells are too low, patients often present being very tired or short of breath. And they used to go to the gym and be able to do an hour workout, and now they can only do half an hour or 20 minutes. And these presentations are often delayed because healthy patients will just blow it off and think they just had a long day at work or didn't sleep enough. And oftentimes we'll see patients who have had weeks and weeks of being tired before they actually come to medical attention. If one's platelets are too low, one can start to bleed more easily. So this is usually not in the form of a catastrophic, life-threatening bleed, but one starts to see little red spots on their skin as evidence of very small microbleeds in their skin, or even some bruising, be it on their skin or when they brush their teeth and their gums, and certain places where one is predisposed to localized trauma such as that. But this is how patients these days present. There's a small subset of patients we find on drawing blood for other reasons that we have abnormalities that then we diagnose leukemia. So getting to how we actually diagnose it, it generally requires a bone marrow biopsy. So the healthy bone marrow is inside of all of our bones, but the easiest place to access it in an adult is in the back of one's hip. And that's where we generally do a bone marrow biopsy. This involves sticking a very small needle into the hip bone, and we draw out a liquid sample with a syringe. And the second part is we do a core biopsy, which means we kind of drill down a little bit with that needle and take out a very small cylinder, sort of like a geologist takes a core of the earth. We take a little core of the bone marrow, and we send all of these to our collaborating pathologists to take a look under the microscope so we can review to figure out what the issue is. If in that bone marrow biopsy, we see there are 20% or greater, all right, myeloblasts, these early cells, if they make up more than 20% of all the cells in the body, that meets the definition of acute leukemia. And if these blasts are of a certain flavor that are what we call myeloid, so they have certain markers that tell us this, then this meets the definition of AML. And that's how we generally diagnose AML. There are rare cases where these blasts will spill out into the blood, where a bone marrow biopsy may or may not be essential to the diagnosis, but it's done anyway to get other information. And there are other rare cases where the AML cells don't present in the bone marrow, but they present as a solid tumor, right? This is called a chloroma or a granulocytic sarcoma. These are the terms for that. And the tumor itself is a mass of these AML cells. The bone marrow biopsy is really important these days to not only diagnose the type of acute leukemia, and AML in this case, but with AML, it is also important to then be able to do the analysis we need to select the best treatment. We've known for decades that when we look at the AML cells, we can glean certain information from the DNA, which is the blueprint of all of our cells, that can not only help us predict the prognosis, meaning how will one do with treatment, but these days, given we have different treatments to offer, we are starting to be able to use that information to choose not only the initial treatment, but certainly the subsequent treatment, in hopes of being able to attain a good outcome for every patient. So these studies generally involve analyzing the DNA in the cells of the leukemia cells, and they're on two levels. One is called cytogenetics, okay? And that looks at the chromosomes in a basic way, and generally looks at your chromosomes in the leukemia cells and asks, are there big pieces from those chromosomes missing? Do they look misshapen? Do you have an extra copy? Are you missing certain chromosomes? And so it really not looking, that cytogenetics is really not looking at individual genes, but just looking at the shapes and the structure of the chromosomes. And that for decades was the most traditional way to figure out how patients were going to do and how to best select therapy, most commonly trying to choose between a chemotherapy-only approach or one involving a bone marrow transplant. Unfortunately, even though we were able to get that information, more than half of patients did not have abnormalities in their chromosomes when we looked at the cytogenetics. And so in the last probably 15 years, through large sample banks of patients with AML, we went back and really were able to find a series of genes that were commonly mutated in AML. So again, cytogenetics is looking at the shapes of these chromosomes, and then the genetic analysis is looking at mutations in specific genes. And every leukemia center you go to these days will have their own panel and be able to analyze very quickly these specific genetic mutations. And this has become really powerful to help us prognosticate for patients, dictate therapies based on how we think patients will do. And increasingly, as we move forward, it's also influenced therapies because we've now developed therapies that target these specific genes. So, it's been really exciting these last few years in progress in acute myeloid leukemia. The diagnosis remains with a bone marrow biopsy, but the information that's gleaned from there generally will dictate how we design the therapeutic approach these days.